A 65-year-old male patient is diagnosed with an obstructing malignant tumor in the descending colon. In the context of managing malignant colorectal obstruction, what are the specific indications for the placement of enteral stents?
Enteral stents are used for palliation in patients with surgically incurable colorectal cancer who are not suitable candidates for surgery due to advanced disease or poor general health. Additionally, enteral stenting can serve as a bridge to surgery, aiming to avoid an emergent two-step procedure, allowing optimization of the patient's medical status and preoperative staging, including colonoscopy. This approach helps in reducing postoperative morbidity and the need for a stoma. There may be limitations such as not being feasible in certain cases with acute angulation of the bowel, such as the colonic flexures. Comparable survival has been shown in randomized trials with up to 36 months of follow-up.
What are the contraindications for stent placement in the management of malignant colorectal obstruction?
Emergency surgery rather than stenting is recommended for patients who present with complete colonic obstruction and evidence of systemic toxicity, as they may have already developed colonic ischemia or perforation. Stent placement is also contraindicated in patients with intra-abdominal abscesses, as it can exacerbate the existing infection. Additionally, stent placement is relatively contraindicated in patients with persistent coagulopathy despite treatment, as it can increase the risk of bleeding complications. Distal rectal lesions, particularly those within 5 centimeters of the anorectal junction, are usually avoided for stent placement due to the potential for severe pain, tenesmus, and rectal bleeding. Furthermore, the use of the anti-angiogenic agent bevacizumab has been associated with high rates of perforation in patients receiving stents.
What equipment is used for colorectal self-expanding metal stents?
Uncovered stents have a meshwork of bare wire, while covered stents have a covering material. Another variety of stents called the through-the-scope stent is also used. This can pass through the channel of the endoscope and opens from the proximal end above the tumor, unlike none through-the-scope stents that opens from the distal end below the tumor. Covered stents are mainly used in cases involving malignant colonic fistulas. While covered stents theoretically offer a decreased risk of tumor ingrowth, they are more prone to migration compared to uncovered stents. However, studies have not shown a significant advantage for covered stents.
What is the procedure for placing colorectal self-expanding metal stents?
Colorectal self-expanding metal stents are typically placed under endoscopic guidance, preferably with the aid of fluoroscopy. This approach is especially advantageous when the obstruction is proximal to the rectosigmoid region or when the colon has a tortuous anatomy. During the procedure, careful insufflation should be used to minimize the risk of perforation due to a closed-loop phenomenon between the obstructing lesion and the ileocecal valve. Carbon dioxide insufflation is now preferred over room air insufflation for endoscopic procedures, especially in high-risk cases. If necessary, a second or third stent can be used in an overlapping fashion with the first stent to completely traverse the stricture. Interval overlapping stent placements may also be necessary due to stent obstruction resulting from tumor growth through the stent or at either end of the original stent. Patients with stents in the transverse or right colon can resume normal diets, as the stool in these sections of the colon is typically still in a liquid form.
What are the adverse events associated with colorectal self-expanding metal stents placement?
Colorectal self-expanding metal stents placement carries certain adverse events. A systematic review has shown that stent placement is associated with an overall complication rate of approximately 25%. The most common adverse events include stent migration, recurrent obstruction, and perforation. Stent migration occurs in about 12% of cases, while recurrent obstruction and perforation are seen in approximately 7% and 4% of cases, respectively. Other less common adverse events include abdominal pain and bleeding. Perforation can occur immediately or be delayed, with a higher likelihood in the distal colon due to sharp angulation and redundancy. It may be associated with peritoneal seeding and worse oncologic outcomes. The anatomy of the left colon predisposes the colonic folds to drape over the two ends of the stent, leading to excessive tension at the points of contact and subsequent pressure necrosis.